Good afternoon to all of us, and welcome to this week's presentation on the maternity service agenda. This week will be led by Dr. Betty and Dr. Gyogluu on the topic diabetes in pregnancy. I'm sure this common situation that a lot of us as practitioners in maternity, whether doctors or midwives or health practitioners taking care of pregnant women, would encounter and may have encountered before. So it'd be good to get knowledge updates in the management of diabetes in pregnancy. Just some few household keeping issues to take note of. You'll be unable to unmute yourself. So if you try unmuting yourself, you realize that they will give you a response that the host has disabled that. This is to prevent people from inadvertently unmuting themselves and distracting the presentation. However, the chat box is available all throughout Betty's presentation. And so if your question may be forgotten at the end, you could type it out in the chat box so that we read it out and have a discussion at the end of the presentation. So kindly join me in welcoming Dr. Gyogluu and Dr. Betty to lead us with the presentation. We're hoping to make it quite brief as usual, and then we allow time for discussion. And so we're hoping to be out of this webinar by 4 p.m. Thank you so much for joining us. Dr. Betty, the floor is yours. Thank you. Bye.
Hello, everyone. Good afternoon. First, I hope you can hear me.
Yeah, your voice is quite faint. If you could kindly speak up or speak into the microphone.
First, can you hear me now?
Yes, please.
It's fine now. Okay. So, my name is Dr. Gyogluu, and today I'll be taking us through diabetes and pregnancy, and my supervisor is Dr. Gyogluu. So this shall be the outline of the presentation. So let's talk about diabetes. What is diabetes in general? So diabetes, we say, is also a group of metabolic diseases in which there's high blood sugar levels over a prolonged period. So these high blood sugar levels, if left untreated, can lead to both acute and chronic complications, some of which we'll talk about as we go on in the presentation. And it's caused by an interaction of different factors, which include genetic and both and environmental factors. The environmental factors are becoming a leading. They are found to be influencing the levels of, the figures of diabetes that are being diagnosed. And then the factors leading to diabetes include reduced insulin secretion or decreased glucose utilization and or increased glucose production. So diabetes in general, over the past 20 years, the numbers have tripled. So somewhere in 2000 and the year 2000, we were recording about 151 million cases. But a study that was done now gives us a report about 463 million cases. That was in 2019. So that you can see that in the population, the numbers are really increasing. And it's estimated that about 3 to 10% of pregnancies are complicated by diabetes. So a study that was done by the International Diabetes Federation in 2019 showed that globally, an overall prevalence of diabetes in pregnancy was about 15.5. Out of this, 12.8 was due to gestational diabetes, 1.3 was due to pre-existing diabetes, and 1.3 was due to diabetes that was first detected in pregnancy. So how do we classify diabetes? So in pregnancy, we either have patients who already have their pre-existing diabetes, be it type 1 diabetes or type 2 diabetes presenting to us, or patients that we diagnose with gestational diabetes, but due to the figures at the time of diagnosis, we can then stratify them into pre-existing diabetes or true diabetes. So some of the differences between diabetes and pregnancy and gestational diabetes, because it tends to confuse most of us a lot. So usually diabetes and pregnancy, we diagnose a patient as having diabetes and pregnancy if the pregnancy, the patient's pregnancy. Hello? Hello?
We can hear you. Go on.
Yes. So if we diagnose a patient with diabetes and pregnancy, if the hyperglycemia was diagnosed for the first time during the pregnancy and meets the WHO criteria for diabetes in a non-pregnant person or non-pregnant state. Also, this diabetes in pregnancy can occur in any time during the pregnancy, which most commonly is during the first trimester. And when we talk about gestational diabetes, it's usually hyperglycemia that does not get to the levels of a non-pregnant state. Also, it's hyperglycemia diagnosed for the first time in pregnancy and usually occurring around the second trimester, usually around 24 weeks, 28 weeks. So what is gestational diabetes? As we already saw in the previous slide, is hyperglycemia occurring the first time in pregnancy. So usually during pregnancy, the insulin demand increases. Even though the increasing demand increases, the insulin sensitivity somehow is reduced by the action of certain hormones, some of the placental hormones such as placental lactogen, human placental lactogen, other diabetogenic hormones as well, which include cortisol, progesterone, estrogen. Usually in the first trimester, insulin sensitivity does not change or is just a little bit high. But as the pregnancy progresses around the second trimester, that is when we start having the sensitivity of insulin being reduced. And that's where the cascade of other metabolic processes occur, such as increased lipolysis and the likes, which is highly influenced by this human placental lactogen, which causes an increased fetal demand or increased fetal diversion of glucose and then maternal and the decreased maternal use of the same glucose. So most women revert to normal glucose tolerance, glucose pattern, but have a substantial risk, which is about 50 to 60% of developing type 2 diabetes later in life, and a percentage of about 5 to 10 develop type 2 diabetes immediately after delivery. So usually we know what happens with our glucose and how insulin plays a role in this. So usually with the type 1 diabetes, or let's say the overt diabetes, or those who we end up diagnosing as or type 1 diabetes, we can see that when the sugars in the blood are high, with the insulin deficiency, the pancreas is unable to produce the hormone insulin, which should be released to facilitate the metabolism of this glucose by the cells. And that will lead to diabetes type 1 or overt diabetes. But with respect to usually the type 2 diabetes or GDM, what we realize is that even though the pancreas can produce some insulin, the sensitivity to this insulin is decreased, causing the glucose to build up in the blood, and then that will lead to some of the complications that we tend to see. So let's say the flow chart. So if this glucose is high in the blood, this glucose is able to cross the placenta. When it crosses the placenta, it increases the glucose, the glucose levels of the fetus. So the fetus tends to produce a lot of insulin, thus causing the hyperinsulinemia. And this hyperinsulinemia delays the synthesis of surfactants by the lungs. That leads to some complications that we see in them, such as the respiratory distress syndrome. It also causes some form of oxidative stress, that causes hypoxia and sometimes leads to stillbirth, and also it also ends up causing an increase in the levels of erythropoietin, causing a high level of red blood cells, like polycythemia, production of red blood cells. And this in turn sometimes leads to jaundice in these fetuses when they are born. So what are some of the effects of pre-existing diabetes on pregnancy? So women who already have their diabetes prior to getting pregnant, if their sugar levels are not being controlled, it increases their risk of miscarriages. Also, it also increases their risk, even when they do get pregnant, it increases their risk of developing preeclampsia, of developing infections, and also causes an increased rate of CS in these patients. What about the fetus? What happens to the fetus? We realize that most of them tend to develop congenital abnormalities. So there's a table here that shows us how the levels of the HbA1c increases the risk or not of a mother having a fetus with congenital abnormalities. So you realize that if your HbA1c levels are within the normal, you have no risk of, the risk is not increased. The risk of having a fetus with congenital abnormalities is not increased. However, if your HbA1c levels are more than 10%, then it increases your risk of having fetuses with, or a pregnancy with a child that has, a baby that has congenital abnormalities to about 25%. It also cause perinatal mortality and increases the risk of unexplained intrauterine fetal death. What about the risk of, the effects of pregnancy or pre-existing diabetes? One of the common ones we see is hypoglycemia. Hypoglycemia is that when women get pregnant, their taste increase and changes, they sort of nausea and vomiting, and this sometimes leads to hypoglycemia because of the low caloric intake. Some of them also progress. The progression to diabetic retinopathy is increased about twofold. The same thing with the nephropathy. And obviously, pregnancy too increases the demand of insulin required for the mother. So with respect to GDM, what are some of the risk factors? So the risk factors play a role in which screen our patients as we go along. We realize that when a patient comes to you, you have to know that this patient is a patient I have to screen or not. And some of the risk factors will guide you so that you can know what to do with this pregnant woman. So some of the risk factors include the ages above 25 years, advanced ages, a BMI of above 25, or a weight above 90 kg, previous GDM, family history of diabetes in first degree relatives, so a previous macrosomic baby, which is very common. Some women come first pregnancy 4.2, second pregnancy 4.2, and they've never been screened for gestational diabetes. Polyhydramnios, large for date baby in current pregnancy, and previous unexplained stillbirth. So what are some of the signs and symptoms that we usually see? On the regular video, a woman with GDM wouldn't come with some of these signs and symptoms unless this person already has diabetes prior to pregnancy and probably wasn't even aware or is aware that he or she has diabetes. So you have the increased thirst, the tiredness, the nausea, frequent urination, blood pressure. But we should note that most of them do not even come with any symptoms at all. So usually when do we screen for diabetes and for gestational diabetes? We usually screen for gestational diabetes between 24 to 28 weeks of pregnancy. Now, how is the screening done? There are two forms of doing the screening. So we have the clinical screening where you take your history, taking into consideration the patient's risk factors, the past medical history, and the examination findings, when you see this woman after taking the weight, the woman more than 90 kg, is the BMI more above 25, and this same woman, how is the fundal height? Is it above the, is it corresponding with the gestational age, or is high above that of the corresponding age, and all of that. Then we have the biochemical screening, which we do with our oral glucose. Then we have the epidemiological screening, which can be universal or selective. With the universal screening, so this involves screening all pregnant women for diabetes. Okay. Not, I mean, some have proposed that the practice of giving the 5 grams glucose at any time during the day, whether the patient has fasted or not, said that if the patient records the cutoff values or above the values that cause sugars above the cutoff value, they are followed up with a 100 grams per hour OGTT test. But this test is quite expensive, even though it is very sensitive. The selective, or let's say the selected screening, this way we screen women who have risk factors. Okay. However, it has its disadvantages in that we will trying to see those who have risk factors. We will leave some people who do not really fall into the category of the risk factors, but may still have gestational diabetes out of this. Okay, so it said that it is about 56% specific and 63% sensitive. And it implies that about 37 to 50% of women with diabetes in pregnancy may go unnoticed and may suffer adverse outcomes during the pregnancy. So other screening methods, so the fasting blood sugar, which is useful, which is a useful component of the OGTT. Most GDM patients have high postprandial blood glucose because of the deficiency of insulin to respond to the high load. Okay, but we realize that we don't use the RBS often because the RBS is, it doesn't give us a good, let's say, a good figure as to how the patient's sugars are, but it is very helpful in emergency situations such as patients presenting with diabetic ketoacidosis and the likes. Glucosuria is also another screening tool that helps us to, let's say, pick patients that we can further screen for gestational diabetes. So when you have a patient who has glucosuria 1+, she can be further screened, or a patient who has heavy isolated glucosuria, that's 2+ and above as well. So any glucosuria with ketonuria strongly suggests that this patient has diabetes. So we have to do an RBS immediately to know what to do or how to manage this patient. However, the glucosuria is not a diagnostic test, but it is a screening process that will follow further investigation. Other investigations that can be done for these women is a blood sugar profile, a glycated hemoglobin, that's the HbA1c. We also do a scan to see the fetal world, Doppler studies, and the non-stress CTG, which will be very beneficial for these women diagnosed with gestational diabetes or diabetes towards the end of the pregnancy. Fasting blood sugar, we do the screening for infections such as the urinary and urine CS, and also the creatinine, know the level of nephropathy that these patients have. So how do we diagnose diabetes in pregnancy? So diabetes in pregnancy is diagnosed when the patient has a fasting blood sugar of greater than or equal to 7, and then a 2-hour glucose of greater than or equal to 11.1, or a random plasma glucose of greater than or equal to 11.1. So if a patient comes and then you do an OGTT, which is what we commonly do in our setting. Yes, this is what we commonly do in our setting using the 75 grams of oral glucose. And then this patient during the fasting the glucose levels is more than 7, greater than or equal to 7. And then after 2 hours is greater than or equal to 11.1. This patient is tend to have diabetes in pregnancy and not gestational diabetes. However, if the patient comes and after this 75, this oral glucose tolerance test is done, and the fasting blood sugar is between 5.1 to 6.9, and then 1 hour after the 75 grams oral glucose is given, is more than 10.0, or 2 hours plasma glucose is between 8.5 to 11.0, then this patient tends to have gestational diabetes. So the cutoff points are very important. So you can see that for diabetes and diabetes in pregnancy, the cutoff point for the fasting is above 7 and above. But when it comes to gestational diabetes, it's 5.1 to 6.9. The same with the postprandial, after giving the glucose, the cutoff point 2 hours, after the 2 hours is 11. So 8.5 to 11 for gestational diabetes. But for that of diabetes and pregnancy, it's about 11.1. So take note of the cutoff so that you can stratify these patients or put them in their right diagnosis. So how do we manage our patients? So we provide a preconception care for all these people, because especially those who have pre-existing diabetes, because from the beginning we saw how their risk, depending on their glycated hemoglobin levels, they are at increased risk of having congenital malformations, as well as having a lot of recurrent abortions and the other complications that were mentioned. So we need to provide preconception care for these women. Okay, so these women are educated to maintain an adequate nutrition, glucose control before conception and during pregnancy, all the way to postpartum. So also our goal is also to keep a close to normal glycemic control prior and throughout pregnancy, because this will offer benefits to the mother and to the child as a whole. So our management, as I said, includes a pre-pregnancy counseling, that is preconception counseling. These women should book as early as possible. Our multidisciplinary approach, which will include our obstetricians, our nutritionists, our pediatricians as well, and endocrinologists if one is available, or the help of an internal physician specialist. The control of blood glucose, frequent antenatal visits, to ruling out infections, to ruling out complications for both mother and child or fetus. So how do we approach our management? Okay, so early referral to specialists is very essential. So if you are in a CHIP zone or in a polyclinic, and then you happen to, for instance, in the CHIP zone, you might not be able to do an OGTT. But if you see a patient and then you suspect per the risk factors that this woman is probably having gestational diabetes or just having diabetes in pregnancy, an early referral will be helpful to the mother and to the fetus as well. Or you have a patient who has been having recurrent miscarriages, and then this time around is pregnant, early referral is very helpful. So a collaborative effort among obstetricians and midwives, endocrinologists, ophthalmologists, registered dietitians, and the nurse educate. As I said, it's a multiple disciplinary approach. So all these people play a big role in the management of these patients. So we also have to individualize our treatment for our patients. So our glucose monitoring, our nutritional therapy, which is very important. We cannot manage all of them on the same nutritional level, depending on their risk factors and all of that. They are managed as such. So pharmacotherapy, exercise, which plays a very big role, and weight management strategies, as well as psychological support, because managing diabetes is not easy, especially when you are pregnant and your demand is very high. You tend to eat a lot and all of that. It's very difficult for you to tell a pregnant woman that you have to cut down on the bowl of food you take, or the bowl of tea that you eat, or the frequency at which they eat. So the psychological support it plays a very big role, and it's very important. So when we do diagnose them and then they are on treatment, we should always counsel them at every visit, and then reinforce what they are supposed to do. So preconception, what do we usually do? What we provide contraception to all women in their fertile age, okay, who have diabetes where appropriate, so that we can optimize their 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 glycemic levels before they get pregnant, okay. And then we have to what actively discourage pregnancy if the HbA1c levels are above it. So these women, if they're already known to you, maybe they had a previous pregnancy that they lost because of their diabetes. This time around, even before you discharge, you to counseling them when they now come to you, that they intend to get pregnant, and you are working them up. We should target a glycated hemoglobin levels of less than 8 for optimum outcome for the mother and the fetus. We also offer monthly measurements of the HbA1c levels for women with diabetes who are trying to get pregnant. Okay, and then those who are also on certain medications such as the ACE inhibitors that might lead to they might have teratogenic effects on their unborn children. All those medications should be stopped. Now, when they finally get pregnant, antenatal mama, what do we do for them? So our detailed history is very important. The screening, if at that particular point, they are already not diagnosed of diabetes, but maybe the previous pregnancy, they had DDM, to screen them as early as possible to see if they need to start treatment or not. Then we offer the OGTT as soon as practical, as already said, around the 24 to 28 weeks, if the booking screening was normal. Then we also offer OGTT as soon as possible for women with previous GDM, and to repeat at 24 to 28 weeks, which we already said. Educate, please, can you hear me now? I hear my voice is quite low.
Yeah, please just raise up your voice.
So we also educate all patients on their condition and management. As I said, the counseling of these patients is very, very important. So these patients are also instructed and taught on how to check their glucose themselves. Okay, so they're able to check the glucose themselves, especially those that are very compliant and educated. You let them get the machine, and then they monitor their glucose from time to time, and then the plan you have for them, they come with these profiles, these glucose profiles. So we admit newly diagnosed who need medication for glucose profile. So you admit them, you put them on the medication, subsequent glucose profile to make sure they have a good control. Then you can subsequently see them on ANC basis and as on OPD basis. So you admit other patients overnight for inpatient glucose profile, especially those who cannot do it by themselves in their homes, at least once, twice a month, or more frequently, depending on how the control is and how compliant the patient is as well. So we also have to intensify our fetal surveillance for these patients. So we do our monthly USG, we do our fetal anomaly scan when they are due, we do a CTG, we do our 2-weekly. So we do our CTG 2-weekly, especially after 34 weeks. This helps us to pick up certain things, certain factors before we start encountering stillbirths, and also helps us to know if these women can undergo spontaneous vaginal delivery. My slide has got me. Okay. So all women also diagnosed with GDM should be started on diet and exercise for the first period. Then if that is not working, then we move on to putting them on some form of therapy, pharmacotherapy, if they need to. So some women do very well on the dietary therapy, as well as some moderate exercise for them. So once you diagnose patients of GDM, depending on the sugar levels, this patient can see a dietitian, and then a plan can be drawn up for this patient, and subsequently she'll be seen with a profile to see if with the diet and with the exercise, her sugars are under under control. So the pharmacotherapy should be initiated, but if the glycemic control is poor after 1 to 2 weeks of diet and exercise. So the diagnosis of diabetes and pregnancy, if the sugar level, so if the patient is diagnosed with diabetes and pregnancy, and the fasting blood glucose is above 6.9, and the 2 hours is more than 11.1. So with the RBS above 11.1, in the presence of symptoms, this patient should be put on therapy, pharmacotherapy. Okay, so patients also who are diagnosed in the case of emergencies such as DKA should also be put on therapy, pharmacotherapy. What's our drug options? So our first choice is insulin. Okay, so that's our first. But however, some patients who are diagnosed with diabetes in pregnancy, be it especially the overt diabetes, are sometimes started on the oral medications. And then subsequently, if these sugars are not controlled, then we move to insulin. But those diagnosed with GDM, usually we start them on the oral medications. Commonly used is the metformin, but we can also use glibenclamide. So when a patient is diagnosed with diabetes in pregnancy, so we initially we educate the patient, insulin therapy, we teach the patient how to go about the injections. So mainly we use the mixed-start, the premix insulin, the mixed-start for these patients, and we start at a very low dose, usually around 0.3 international units per kg, because you don't want to start very high and run this patient into hypoglycemia. So you start low and then titrate up. So usually this is just a chart to show how we calibrate the units of insulin with respect to the gestational age. But however, we are not supposed to exceed 60 international units per day for starters. So poorly controlled or diagnosed hyperglycemia in case of emergency in these patients, you have to start with a sliding scale. Usually, as I said, those who come with DK and the likes, you have to start with sliding scale or modified Albertus regime. If the ketones are clear, then you now come to your sliding scale. Then you can now move on to putting them on your mixed-start or pre-mixed-start or your metformin if they need be. The oral medications that we commonly use, metformin and then glibenclamide. Commonly used metformin, our maximum dose is 2,500 per day. Okay. So what are our targets for these women? So when we put them on this therapy, be it insulin and metformin or glibenclamide, or be it insulin with metformin, we have certain targets we want these sugars to be around. So our preprandial or premeal target for women with GDM is 5.3. Then the postprandial, that is 1 hour postmeal, around 7.8 or below, or 2 hours, 6.7 or below. Then for women who already have pre-existing diabetes, so our pre-time or bedtime for overnight glucose should be between 3.4 to 5.5. Then our peak postprandial glucose should be between 5.5 to 7.1. And our glycated hemoglobin level should be less than 6%. So peripartum, how do we manage our patients during the peripartum period? So we have to plan our delivery. Okay, plan our delivery with consultation with a specialist around 36 to 37 weeks at ANC, and you document clearly how you want or when you want this patient to undergo labor or to have a cesarean section, depending on all the factors that pertain to the woman. So it's always better to admit these women and do a strict glucose profile and a surveillance around the 37, 38, 36, 38 weeks. Because some of them will come with unexplained stillbirth. So these patients, we have to do a non-stress CT for them and make sure that their glucose levels are properly controlled. So we usually aim at delivering our women between 39 to 40 weeks. One of the factors is because of the delay in the maturity, in lung maturity in this patient. Okay. And we also give our dexamethasone to aid lung maturation in certain special situations. But we have to make sure that these women, their sugar control is like they have a good sugar control, and it should be under strict surveillance so that you do not run them into any form of complication, be it DKA or the like. So an estimated weight of more than 4 kg, usually we recommend that these women undergo a cesarean section because of the risk of shoulder dystocia. If there is no obstetric contraindication to vaginal delivery is always preferred. So pre-gestational diabetes, an elective CS. So depending on, as I said, the factors surrounding each pregnant woman, you have to individualize their care. The same way you have to individualize their mode of delivery. So an elective CS delivery between 37 to 38 weeks. We have to consider delivery before 37 weeks if metabolic or fetal maternal complications occur. So if the woman now has preeclampsia coming in as a complication, then you can't push this woman all the way to 40 weeks because of dying complications of the preeclampsia. That can lead to eclampsia. So GDM, we advise that the delivery should be no lesser than 40 plus 6 weeks. That means they shouldn't exceed 41 weeks. So these women, you can induce them if there are no contraindications, and then they can go through a successful vaginal delivery. So during labor, they should be the labor should be in the knowing of the pediatrician or the neonatologist, whoever is available. They should also have the glucose, potassium, insulin infusion, which will be given appropriately the regimen. You also monitor them on photograph when they are in active phase. And when they're in active phase, you have to monitor the glucose levels more regularly. Every hour, they should monitor hourly. And the plasma glucose, yes, as I said, it should be monitored hourly, and it should be between 4 to 7 millimoles per liter. And for those that we decide to do a cesarean section for, these patients the cesarean section should be done early in the morning. So if you have 10 patients and 2 of them are DPM or diabetes and pregnancy, those are the patients you should do first before you move on to sectioning other patients. And then the pediatrician and the neonatologist should be in the knowing. The patient should have their insulin dose at bedtime, but then shouldn't be given in the morning. In well-controlled patients with fasting blood sugar, only fasting blood sugar may be done in the morning of the surgery. And make sure that we also have our GKI solutions with. So postpartum, what do? We have to readjust the insulin doses for our type 1 diabetics, especially due to the fact that after delivery, the demand drops, the demand of these women, this pregnant woman drops. So if you keep giving them the same quantity of insulin, you run them into hypoglycemia. So those on oral medications that we give them on metformin and the likes, those medications should be stopped. Then the RBS monitoring of the baby should be done, and then breastfeeding encouraged, because these babies are in a they have hyperinsulinemia going on. So if you do not monitor their glucose levels or encourage breastfeeding, they are having the risk of going into hypoglycemia. And those that have to be sent to NICU, we send them to NICU. If maybe baby was born by SVD and developed shoulder dystocia along the line, this baby should be sent to NICU. Or babies, you check the baby's sugar levels, and then the sugar levels are very low, sent to NICU. Or the mother is unstable and cannot breastfeed, send the baby to NICU. What are some of the complications? We already mentioned some of them initially. So our congenital malformations, which are very, very common, especially in our type 1 diabetics with uncontrolled sugars. And then we have polyhydramnios, fetal macrosomy, which can in turn lead to shoulder dystocia. We have a neonatal hypoglycemia, our hypocalcemia, hypomagnesemia, polycythemia, and the likes. With our mothers, still on the fetal complications, as I said, polycythemia also leads to hyperbilirubinemia, and then sometimes the delay in breastfeeding to also contribute to this. So these babies should be sent to NICU. And then the respiratory distress syndrome, the unexplained fetal, the stillbirths that we can have as well. For our maternal complications, we can have DKA, which is potentially life-threatening to both mother and fetus. And we can have a causing IUFD, and then even causing serious complications for the mother. And sometimes it's precipitated by certain illnesses not known to the mother. We can also have hypoglycemia, spontaneous abortions, as mentioned earlier, and rapid progression of certain microvascular and atherosclerotic diseases, and nephropathy as well, perineal tests in the setting of to shoulder dystocia and having to push out the babies. So what are our conclusions? So the conclusions are all pregnant women should be screened for GDM, especially those with risk factors. So in our setting, in Akwa Regional Hospital, we have moved from screening women with risk factors, and this year we are trying to start employing universal screening for all our women who are pregnant. So I think it's something that we all can pick up. Also, preconception care plays a vital role in achieving good pregnancy outcomes, especially for our women with pre-existing diabetes. So all patients with the gestational diabetes should have an OGTT done 4 to 12 weeks after delivery. As we said, about 3 to 10%, or yes, about 3 to 10% of them develop type 2 diabetes immediately after delivery, and some do develop it later in life. So even after this, if it is negative, every 2 to 3 years, we advise that we still get a screening done for them. Thank you very much. And this is the end of the presentation. Questions or contributions? Thank you.
Yeah, thank you so much, Dr. Betty, for an excellent presentation and teaching us about diabetes and pregnancy. So we will quickly take questions, comments, suggestions from participants. And then after that, Dr. Betty and Dr. Gildas will give us the concluding remarks, and we would be out of here. We have about 70 minutes to the hour, so we can have a good time to have discussions. So just before that, I would wish to ask everyone to check in the chat box. I've seen that people usually ask about the slides and about knowing what topic is next. So if you look at the chat box, I've just put in those processes. So first one is that if you want to know about which topics are next, you just click on either the Facebook page or LinkedIn page and then like that page, and on a weekly basis, you would be updated on what next we are going to present. Then if you want the recording of this presentation, as well as the other presentations we've done, you need to subscribe to the YouTube channel. It's Ghana Medical Help, and the link is what I've put in the chat box as well. If you click on that and you subscribe, you will also have those ones as and when you want to access them. So if you want to ask any question, you have any comment to make to help improve this presentation, kindly electronically raise up your hand, and then we'll unmute you to do that. So whilst we wait for that, Dr. Betty and Dr. Gildas, as well as all those I've made co-hosts who are part of our maternity service agenda team, there are some questions that have been put in the chat box. I'll read them out and then you can help us answer them. So the first one was from Gifty from Kumahi Yebua. She is asking, please, may I know what HbA1c is for checking glucose level? Please, may I know what HbA1c is for checking glucose level. I don't personally understand it, but I suspect she's probably asking the values for knowing the diagnosis or not, unless I don't understand. Dr. Betty, Dr. Gildas, or anyone who would want to pick that up.
I don't particularly understand the question.
Yeah, I suspect maybe. So, Gifty, if you could kindly type this.
Dr. Akatiba, I think she's trying to ask what is the optimal HbA1c, if I'm in her mind.
Like good.
Yeah, I think
like
that
good
was
control.
yes, for pregnant,
Okay.
good control for pregnancy. And I think as Dr. Betty rightly said, it should be below 6. And if it's above 8, we strongly recommend that you do not undergo pregnancy, as in you shouldn't get pregnant. You should get your sugar level well controlled before you get pregnant. So it should be below 6, some say 6.5, so that to achieve good glycemic control before you can embark on pregnancy.
Great. Thank you so much, Dr. Gildas. So, Gifty, if that was what you were asking for, that's the answer. But if not, you could electronically raise up your hand. I'll just unmute you to ask the question or get it clarified if that's not what you meant. Then I don't see any hand up. If you want to ask any question, you can just put up your hand. I would unmute you and then you can go ahead. All right. So whilst we're waiting for that, let's see in the chat box, apart from Gifty's question. Okay, please go ahead. Eugenia.
Thank you. Please, I want to find out if someone is going for cesarean section concerning nail per os, will it be different from the normal number of hours or it will be the same? And also, I have a concern. So those of us who have joined, we joined using a Eugenia's phone, and we are at the ward also with junior staff. So some of them are saying they don't understand. So the next time, I will plead that when you are presenting, you come down a little so that if someone is a junior staff can also understand. Thank you very much.
All right, thank you very much, Eugenia. Well noted. As well, like I mentioned, the video is on the YouTube channel, and you can click and then you would have access to it, so that you, at your own pace, you'll be able to listen to, pause, and think about, rethink, and make your searches and be able to know. We do understand that there's a varied audience base, and that we will try to get it down. But you, as senior staff, Eugenia, one of your roles would be to also help to explain this to the juniors, so that there's a mentor-mentee relationship, because it will be difficult to make it very at the level of a student, because other practitioners will also want to be. So we'll try to come down, but we can't promise that we would make it like a didactic lecture in a nursing school. So let's take note of that. All right. Betty, will you want to address other concern?
Yes, she was asking about the nail per os.
Yeah.
So there isn't any difference in the nail per os for, the duration of the nail per os for these patients when they're about to undergo cesarean section. However, they should be among the first patients you section when you do start the surgeries for the day, because of their risk of hypoglycemia. But we make provision for all of that as well by having the glucose, potassium, insulin infusion, and all of that. But we still insist that those patients be sectioned earliest before other patients. I don't know if Dr. Gildas has.
Yes, I think you are right. But as you rightly said, for instance, those on insulin, they take the insulin the night before, and then their nightly snack. But in the morning before, you just check the RBS and then send them to theater as quickly as possible. And then after the sectioning, you check they will be on dextrose, IV fluids, obviously, about 5% dextrose. Then after they said, you check the sugar every hour and then adjust the insulin accordingly, or correct if you need to correct if there's hypoglycemia, till she starts feeding. Once she starts feeding, the sugar will be well controlled. But You shouldn't let them starve for long. And then for most nowadays, even for all cesarean patients, we recommend that they start feeding as early as possible. So once bowel sounds are present and she's able to sit up, she can start sips and all that. So we just have to check the sugar hourly and then correct accordingly, either with insulin, or if she's going hypo, you give some dextrose.
Great. Thank you so much. Dr. Velda.
Yes, Dr. Betty, very elaborate and interesting presentation. Thank you so much. I have a contribution or two and then a question. It wasn't too clear, one thing. So the contribution is with the fetal surveillance. I saw monthly ultrasound scans and then CTG when you were explaining, so that we can add the umbilical artery Dopplers, because this would influence how frequently you want to assess the state of the patient and then know if you have an intrauterine fetal demise staring at you anytime soon. Also, for the NICU admission of the neonates, I think in our setting, it will be safe to say that all babies born to mothers who have diabetes, whichever type in pregnancy, should go to the NICU, because the baby has been exposed to so much glucose. Now that supply has been cut, so the risk of hypoglycemia is very real. It appeared as though you do a selective referral, but I think looking at where we are as a country, babies will be safer in NICUs. So if you don't have a NICU in your facility, probably that mother should be delivered where there is a NICU so that the baby can be monitored for a while. When it's cleared to come back to mother, then the baby is sent back to the mother.
Great.
So my
Yes, I think
clarification,
she. Yeah, I'm coming. I think she mentioned the umbilical artery Doppler because it's very important because of
okay,
increased rate of placenta aging. But then for the NICU services, I think that's right.
Okay.
All patients where you have a NICU
Okay,
service,
then maybe
you are supposed to send the baby for hourly monitoring of the sugar. Actually, the nadir, that's the lowest point of the sugar, occurs 24 hours after the baby is born. So if you don't have the NICU service, all you have to do is to monitor hourly and then quickly establish breastfeeding. Breastfeeding can also help the baby from going into hypo. But as rightly said, most of them are exposed to glucose in the mother, which is cut off when they are delivered. But then if the sugars are well controlled, these complications, yes, can actually be alleviated. So most of those babies that go into hypoglycemia are those whereby the maternal sugars are not well controlled. And those who come with diabetic emergencies like DKA and HONC. I hope that's clear.
Okay.
Yeah, I think, Velda, you had a question?
Yes, boss. So I think there was a slide in the beginning about how you diagnose gestational DM and then diabetes in pregnancy. Now, in the third row, there was something about the trimesters. I didn't get that quite clearly. So if you could please take it again.
You said at the beginning.
You had 2 columns with 3. Yes.
Is it here?
No. Go.
Forward, right?
Yes. It had 2 gray sort of boxes.
Like a table.
Oh,
it was a table. It was gray
table.
with some
Is it
3
this?
points. I didn't understand the third one.
Was it this?
No, forward. Still go back.
Back.
You had the diabetes in pregnancy first trimester, and then the gestational DM, I think, second.
Ah, you mean this? This.
This, yes. So the third point, I didn't get it quite clear. I don't know if I'm alone. So if you could take it again so that we understand.
You mean the diabetes in pregnancy may occur anytime during pregnancy, including the first trimester. Is it that point?
Okay, it's clear now.
Okay.
I think it moved fast at my end. Thank you.
Okay. Okay.
All right, great. So, Dr. Kwong, your hand is up, or he's lowered it. Okay, that's been lowered. Abdullah, please go ahead.
All right. Thank you very much, Dr. for the presentation. I have just two concerns. One has to do with women with diabetes, especially in pregnancy. What is the preferred gestational age for them to either go through SVD or maybe dissection? And then my second one has to do with is it advisable to induce such women, looking at the gestational age, that maybe per your monitoring of the sugar level and other thing you think maybe stabilize, will it be advisable for you to do induction in such women? Because most of them, we know that they have their babies are either microsomic or maybe they have other conditions that.
Hello. Is it?
I
What's
think we
your
may have
question?
lost him.
Okay. So as he rightly said, some women have conditions that do not make spontaneous vaginal delivery the option of, the preferred way of delivery. I think I did mention that if there are no contraindications to vaginal delivery, that is the most preferred route of delivery. So yes, if your woman has one or two reasons why this woman cannot undergo vaginal delivery, such as a macrosomic baby, let's say the baby is 4.2, the woman is a nullip, or even 4 kg and it's a nullip, you know very well that the risk of shoulder dystocia in this woman is very high. If this woman too comes already having complications such as DKA, you know that also it's not going to be beneficial to the woman if she undergoes spontaneous vaginal delivery. So in the cases of emergencies, if you also do your non-stress CTG and you realize that this woman cannot undergo spontaneous vaginal delivery, CS is the option for this patient. So I think it depends on how you individualize the mode of delivery for this woman. So that should be discussed, and then the necessary test should be done for this woman before the decision is made that this woman should undergo spontaneous vaginal delivery. And yes, we prefer to do our cesarean sessions between 39 to 40 weeks, as I mentioned, because of the delay in the lung maturation. And for induction, we do not want to induce women after 40 weeks, 41 weeks. So latest by 40 weeks plus 6 days, we should have induced our women with gestational diabetes or diabetes in pregnancy. I don't know if that is clear.
All right, great.
Yes,
So
I think to add to what Betty said, so there's no unless there's a contraindication to vaginal delivery, you can allow the woman to undergo SVD. So per what she said, if there's like the baby there's compromise or the baby is big, that one you have to do a cesarean section. But diabetes itself in pregnancy is not a contraindication to vaginal delivery.
great. I think I don't see any hand up. We'll just take the comments in the chat box. I try responding to a couple of them. So those that haven't, I'll read it out and then we'll
But I
take
think
that.
his hand is up.
Okay, then go ahead, please. Gifty.
Hello, thank you very much, Doctor. I think I asked a question earlier on, but my network, I just got cut off. I don't know if you can help me.
Yeah,
Yes,
Yeah,
I
we're
wanted
actually
to.
waiting for you to clarify. So if you can just ask the question again so that.
Yes, so I wanted to know what the HbAC1 is all about during the glucose. You know, we do some tests, the
A1C.
It was
HbA1c. Yes.
truncated.
So what is it about? I just want to know what the test is about. Then the second one is how to do the sliding scale. I just also want to know, because most of the time it's like put a patient on a sliding scale. So I just want to know a fair idea about the sliding scale as well. And during intrapartum, is it also advisable to give the GDM patient 5% dextrose as part of the fluid management? Thank you.
All right, thank you. Yeah, I bet you want to take that.
I think I got the first and the last question, but the middle one, but I'll answer what I do remember. So respect to the HbA1c, it's also called glycated hemoglobin. So it just helps us to measure the glucose control in these women in the past 2 to 3 months. So there's some form of glucose bound to the red blood cells. So, I mean, to the hemoglobin. So, over a period of 2 to 3 months, where you know that our red blood cells die out after 3 months, like their lifespan is 3 months. So, during the 3-month period before they finally die out, before their lifespan is up, the level of glucose bound to these blood cells is what we measure. And it helps us to know that, okay, in the last 3 months, this has been the patient's glucose control. Is it good on the medication that the patient is currently on, or is it not, or it's the patient needs further titration to their medication? Or if the patient hasn't even been diagnosed with diabetes, it helps you to know that, oh, this patient has some overt diabetes, but didn't even know that he and she had it. And respect to the second question about giving glucose intrapartum, if I'm right, 5% glucose. So it's all about your monitoring, okay? There are infusions you should have available. If this patient during the active phase, I mean the latent phase, you'll be monitoring the sugar levels as you should. And in the latent phase, you'll be monitoring the active phase, you'll be monitoring the hourly as you should as well. And then at any point in time, the sugar levels are now low and 3.3, then you know that you have to, or let's say they are getting to the lower limit, then you know that you have to start running out the dose for this patient. And if it's hypoglycemia, you know you have to give your patient your 50% glucose. So I don't know if that is a bit clear for this patient, I mean, for Madam Gifty.
All right. So, Gifty, if it is, that's fine. Otherwise, you can put up your hand and then go at it again. Dr. Was it Anyeka? I saw your hand up, but she's lowered the problem. I don't see any hand up. Can we take the questions in the chat box, or someone has a comment? If you do, you can put up your hand. All right. So let's take a look at what's in the chat box. I think the next question after Gifty's was she was asking how the sliding scale is done. She wanted an explanation. Will you want to take that, Dr.
Oh, Dr. Katibayi.
Sorry?
It's almost you are offering. So,
She's saying that you are the physician, Akatiba.
No, she's the one doing the presentation. But if you want me to answer it, I can. So the sliding scale is in where things are done right. Frankly, you won't see anything called sliding scale. It's a very reactionary measure, and as a physician, I would not recommend it. But of course, we have to talk to what we have available. So, you usually do it 4 hourly. Once the sugar goes, there was an initial question which I had already answered in the chat box. But putting it in context, usually when the woman comes and the sugars are high, we would want to initiate sugar control in an emergency setting or high dependency unit. So you would want to start normal saline, as with the modifier Alberti. And then that is usually monitored hourly, not 2 hourly, not 4 hourly, every hour you have to monitor. Once the sugar drops to less than 14, some people put it 13, you switch to what is called the sliding scale. And then that is done 4 hourly. And then these are the things that you shouldn't put in your head. Nobody will say that you should keep those values in your head. Every emergency, every obstetric emergency would have the sliding scale. In the standard treatment guidelines, there's a beautiful box that has been drawn there. And so usually, depending on what you check, whether it is between 9.1 to 12.1 or whatever, we would go to the sugar levels. And so the insulin levels to give. And you do it 4 hourly. And the thing is that once you start a sliding scale, then the next thing to start taking is what's the long-term treatment, because you can't keep, like we say, you can't keep sliding someone. So let's take note of that. The 4 hourly check, where is best done, we don't talk about modified liabilities or sliding scale. What they do is to use a perfuser, which delivers the insulin at the level, like gives it in aliquots, in small amounts, like the pancreas would have done in your body. So that's typically how that one goes. I think we are running out of the time, so maybe I'll just read a couple of the comments which you have already answered that, and then we can take the concluding remarks from Drs. Gildas and Dr. Betty. So the other one was about the OGTT, whether you can check it after 28 weeks. Dr. Betty Gildas, can you do that? OGTT after 28 weeks.
Oh, yes, you can.
Fantastic. All right.
It's just advised to do it between 24 to 28 weeks. Because
Great.
That's when the diabetogenic hormones come into their peak. So if there's any defects in metabolism of glucose, that's where you find it. But I can do it after.
Okay. So somebody also asked, can the fetus be diabetic whilst the mother is not diabetic?
Oh, no, we haven't come across that. That's no.
Okay,
unless
great.
it's
Then
type 1.
fantastic. Then somebody's asking about how to manage a patient on, is it better to manage a patient on mixtard or combine glibenclamide and metformin? I think Abdul Azong, I would say that this you may need to contact us so that then we can put it in. It's going to be a long talk regards it. And it also depends on, like I sent you a direct message, it depends on whether it's a pregnant or non-pregnant woman. So if you can get in touch, I'm sure we can talk over it. Then the last one is, please, is it important to give all gestational diabetes patients dexamethasone at 39 to 40 weeks before delivery?
No, that we send them to 39 weeks because we want the lungs to mature, because there's late maturation of the fetal, and obviously because of the insulin that interferes with surfactant production. But even if you are supposed to give in preterm, let's say below 37 weeks, you have to put them on sliding scale. If not, the steroids itself can derange the sugar, causing hyperglycemia. So you have to be careful with that. We will not recommend to give it after 38 weeks. But then if it's preterm and you are supposed to give, you have to admit the patient and make sure that she's under surveillance and she's on the sliding scale, so I can correct the resulting hyperglycemia.
Fantastic. So we'll end it off with Dr. Salam's contribution. So this is an insightful presentation. It's indicated from the presentation that elective CS is recommended for those with gestational diabetes with estimated fetal weight more than 4 kilograms. In the face of the evidence suggesting that more than 500 CS cesarean sessions in women with gestational diabetes and estimated fetal weight greater than 4.5 will it be necessary to avoid one case of permanent brachial plexus injury. With this in mind, is it a pragmatic approach to continue sectioning gestational diabetes in pregnancy with weight more than 4 kilograms? So he's asking about the fact that more than 500 CS in women with GDM with an estimated fetal weight greater than 4.5, and whether it's the way to go to avoid permanent brachial plexus injury. Dr. Gildas, what's your take on
The
this?
aim is not to just avoid brachial plexus injury. There are a lot of other injuries that can occur when the baby is big, and more so in diabetic mothers. Even a normal sized baby in a diabetic mother can suffer what we call shoulder dystocia because of the fat distribution during the growth of the fetus, which is asymmetrical. Most of the fat is distributed around the abdomen and the shoulders. So even with normal sized babies, and shoulder dystocia, we all know it's a deadly condition. I don't know if we have done a presentation on it already. So it's advised that once the baby is macrosomic, you do a cesarean section. But because, as I said, even with normal weight babies, there's a risk of shoulder dystocia. So to prevent not just brachial plexus injury, but a lot of other injuries that can come with a labor that is not progressing or a baby that will not come out, it's better to section when the weight is about 4 kg in Ghana. But outside, some of them say 4.5, but we use 4 as macrosomia.
Great, fantastic. So we would highlight a comment from Dr. Moiba about diabetes retinopathy and its contraindication to SVD, as well as the fact that it's a preventable cause of blindness during SVD. So this is well noted. Some of us, even in kidney practice, back in the day, where screening programs were a problem, even in a non-pregnant woman who has diabetes retinopathy, they usually will say that think about it, that what's happening in the eyes is happening in the kidneys as well. So you would have heard of microvascular complications of diabetes. So you just place on that we just need to control that sugar well in the pregnant woman. Thank you so much,
Dr.
Dr.
Katiba, let me come in. I mean, time is fast spent, but so with regards to that, maybe it's a recent study, but it's showing that retinopathy, that the pregnancy does not actually affect that aspect. Yes, there's accelerated microvascular damage when you get pregnant, but retinopathy is not part. So it is advisable that if a woman has that before she becomes, or if she's trying to get pregnant, it's advisable to see an ophthalmologist and then correct whatever is causing that. But pregnancy, per some guideline, pregnancy is not known to accelerate that. Maybe if it's a new study, if he can please share that as well, that would be very great. Yes, but to conclude, let me comment before you go. Yes, so as we all know, diabetes in pregnancy is one of the commonest conditions in pregnancy. Actually, according to in the US, is a common medical condition in pregnancy, and obviously a burden to maternal and fetal health. So carbohydrate metabolism changes in pregnancy, actually, because it needs to provide the fetus with more glucose. So what happens is that pregnancy itself is actually a state of maternal starvation, so that glucose will be spared for the fetus. So there's reduced insulin sensitivity and increased maternal metabolism, which actually causes insulin clearance. And this effect is brought about by a lot of placenta hormones like estrogen, progesterone, cortisol, human placenta lactogen, which peaks around 24 to 28 weeks. And that's why the test is rightfully done at that time. So, and GDM, we all know, as Dr. Bates rightly presented, there's a 7-fold chance of women with GDM getting type 2 diabetes later on in life. So even after the postpartum, that's when we check the sugar, when we do the OGTT at 4 to 12 weeks, it's advisable that these women should continue doing OGTT every year or every 3 years, since there's a 7-fold increase of getting diabetes. Yes, and this is obviously due to changing diets and lifestyle, and the issue is likely to worsen. So universal screening is recommended, which we are trying to start in the Upper West Regional Hospital as a beginning of obstetric care in Northern Ghana and Ghana as a whole. So universal screening is recommended so that the necessary interventions can be instituted. Thank you.
Okay, fantastic. So thanks so much for joining us for today. We are glad that we'll be able to have a good discussion about diabetes. Apologies, we exceeded the 1 hour mark, but it was because of the questions, and I'm sure it was an insightful discussion as well. Yeah, next week we'll look at another topic. We kindly follow our social media handles, like I put up in the chat box, and when that is up, we'll put it there, as well as the YouTube page if you want the record, and I've just put it up just right away. So till next week, we'll say take good care of yourselves and God bless us all. Thank you, Dr. Betty. Thank you, Dr. Gildas, for an excellent job done. Bye.
Right.